Okay, so regarding the minimal criteria, so it means you should have a very low threshold for treatment. It doesn't mean that you shouldn't rule out all the differential diagnosis. Always, if the patient came with acute PID, you have to rule out the appendicitis, rupture ectopic, okay, torsion of the ovarian cyst, as well as endometriosis. Okay, so they are the diagnostic tool to rule out. Okay, for appendicitis, sonography will help, or there are some scoring system. Okay, and in case of rupture ectopic, always pregnancy test should be done and ultrasound should be done, like transvaginal or transabdominal ultrasound. And ovarian cyst will be visualized. If there is a torsion, it will be visualized in the ultrasound as well, even in endometriosis as well. Okay, so the minimum criteria. Okay, the same symptoms is seen in all the cases of differential diagnosis, but you have to rule out. Okay, so rule out, there are different diagnostic tools to rule out. Okay, so am I clear? अच्छा, internet एकदमै डिस्टर्ब छ है. Okay. So let's start with when the inpatient treatment is indicated. Okay, am I clear? All कुरामा clear भयो?
Yes, sir. Yes, sir.
Okay. Okay. So indication of inpatient treatment. In inpatient treatment, when the surgical emergency like appendicitis, ectopic cannot be ruled out. Okay. So that's why we have to rule out those, though they are the differential diagnosis. If we cannot rule out, we have to admit the patient and do workup. Okay. So that is the one indication of inpatient treatment or admission. Okay. If the patient is pregnant, then also we have to admit, because it could be ectopic pregnancy. Okay. Or there could be, rarely there could be pregnant or intra as well. Okay, but ectopic should be ruled out if the patient is pregnant. HIV, if the patient is HIV positive, or if the patient do not respond to the oral treatment. Okay, oral antibiotics. If the patient unable to follow up or tolerate the oral treatment, and the patient has severe illness like nausea, vomiting, fever. Okay, and there is obvious abscess, TO abscess or suspected pelvic abscess, then we have to admit the case. Okay. So now let's discuss the management. Our goal is to eliminate the acute infection and prevent the long-term sequelae, that is chronic pelvic pain, ectopic, and infertility. So regimen must cover all the aerobes, anaerobes, and common organisms like Neisseria, gonorrhea, chlamydia, as well as anaerobes, gram-negative, facultative organisms, as well as streptococci. Okay, so that's why we give a combination of antibiotics for at least for 2 weeks. Okay, and it should be instituted early to prevent the long-term sequelae. Okay, so it is as effective as inpatient treatment. Those patients have mild to moderate PID, but in severe cases where there is obvious TO abscess, in that case we have to admit the patient. Okay, so now let's discuss about the treatment. So outpatient treatment, remember it's oral therapy for 14 days. Okay, some recommend 12 to 14 days. Some regimen are from 12 to 14 days, and some range from 10 to 14 days. But ideally, they should be given for 14 days. Okay, so what are the regimen? The one is ceftriaxone 250 mg intramuscular single dose. Now it has some guideline recommend 500 mg intramuscular. Okay, then it should be followed by doxycycline and metronidazole for complete 2 weeks. Okay, alternate regimen includes levofloxacin 500 OD. Okay, once daily, or ofloxacin 400 BD, or if you suspect it's a mycoplasma genitalium, or if it's called culture isolated mycoplasma genitalium, then in that case the preferred agent is moxifloxacin 400 OD. Okay, for 14 days. Or we can use azithromycin as well. As azithromycin monotherapy, this is 500 mg IV daily for 1 to 2 doses. Okay, followed by 250 OD for 12 to 14 days, or in combination with the metronidazole. Okay, so these are the oral regimens. So it depends upon the hospital protocol. It should be feasible. Okay, and the regimen which has a better compliance, that should be used. Okay, now regarding the inpatient treatment, the IV therapy should be given. Okay, so cefoxitin 2 gram IV 6 hourly, or cefotitan 2 gram IV 12 hourly. It's followed by doxycycline for total 14 days. Okay, but these treatment regimen A, we do not commonly it's not that commonly available medication antibiotics like cefoxitin and cefotitan. So the preferred one is clindamycin and gentamicin. Okay, so this is preferred even in case of pelvic abscess as well. Okay, so clindamycin 900 IV TDS and gentamicin 2 mg IV loading dose followed by 1.5 mg per kg IV maintenance dose. Okay, so remember, if it's a TO abscess, loading dose is always clindamycin 900 IV TDS followed by gentamicin, and it follows the tablet clindamycin for 56 hourly or metronidazole 500 PD plus doxycycline for total 14 days. Okay, so total 14 days treatment should be completed. And alternate, we can use ampicillin and sulbactam. Okay, 3 gram IV 6 hourly followed by doxycycline. Okay, so you do not need to go in detail of all regimen, but you should know at least in outpatient ceftriaxone, which follows the doxy and metro. Okay, so doxycycline and metronidazole for 2 weeks, and in case of inpatient regimen, clindamycin and gentamicin. Okay, so these are the preferred regimen. Okay, so what about the follow-up? Okay, the patients, those who have been treated as a OPD basis, need to re-evaluate in the 72 hours. Always, if you suspect PID, always you ask the patient to come in 72 hours to reassess. Is there any response? Is the response is poor? Is the hospitalization needed or not? Okay, in that case, patient may be again admitted for parenteral therapy if the response is poor. Okay, so remember, in 10 to 20 out of 100 cases, there is failure rate of OPD therapy. Okay, in that case, we have to admit the patient. Okay, so in inpatient, it is around just 5 to 10% is the failure rate. Remember, always counsel the patient to avoid the sexual intercourse until they and their partner has been completed the treatment course. Okay, so partner treatment and partner workup is also very, very important in pelvic inflammatory disease. Okay, always review after 2 to 4 weeks. Ensure there's adequate clinical response. There's good compliance with the oral antibiotics. There's screening and treatment of sexually contacts, as well as awareness of significance of PID and its sequelae. Okay, so there are surgical management as well. Okay, those patients not responding to the treatment, okay, hospital treatment, IV treatment, and or obvious tuber ovarian abscess, we may have to go for surgical management. Okay, so what we can do, one is posterior colpotomy. Okay, so pouch of Douglas can be opened and evacuate the pus and the drainage of the pelvic abscess. Okay, so especially when it's a midline fluctuant. Okay, we can take a help of ultrasound or CT scan. We can drain percutaneously as well, or laparoscopy or laparotomy. Okay, so remember, if it's a ruptured TO abscess, the patient sometimes may come in shock. So we have to start the treatment of shock, followed by operation of choices to clear all the infected debris. If we pause, okay, together with the abscess, tubes, ovary, all the infected, because they act like a nidus. Okay, when we do not remove, they become the source of infection. Okay, and because of the sepsis, patient's life may be jeopardized. That's why we have to remove all the infected organs. Okay, so in young patient, if unilateral salpingo-oophorectomy may be done if the mass is strictly unilateral or the tubes and ovaries are normal. So in that case, only special cases, if there is a need of fertility preservation, in that case we can do unilateral salpingo-oophorectomy. Otherwise, if there is grossly infected, then in that case we have to remove all the tubes, ovary, and as well as uterus. Okay. So remember, always educate the patient because the sequel is very bad. Okay, so regarding the nature of the disease, long-term complication, and need for proper compliance, changing the sexual behavior, use of the barrier method, especially condom. Okay, and condom plus means you advise the patient to use very effective contraception as well as in addition with the barrier method. Okay, that we call condom plus, means one is barrier method and another is the long-active contraception. Okay, always remember to manage the patient with the sexual contacts. Okay, contact tracing should be done, and male partner treated if the contact tracing, okay, sexual contact during the last 60 days, okay, the preceding the patient onset of the symptoms. Okay, empirically treat the regimen effective against chlamydia and Neisseria. Okay, so always the sexual partner, what to treat with the sexual partner, at least you should cover chlamydia and Neisseria to the the sexual partner. Okay, so male partner. So what we can go, either you have to cover both chlamydia. So either you can give doxycycline or azithromycin, and you have to cover Neisseria gonorrhea. So either ceftriaxone injection or even azithromycin can cover. Okay, so at least you have to cover chlamydia as well as Neisseria. Okay, so any queries? Sorry for disturbance. Okay, so the internet is very unstable in our hospital, so that's why there was
treatment regimen sir outpatient र inpatient को लागि किन फरक हुन गएको छ हामीले त कसको ट्रिट गर्ने हो त मतलब पजिटिभ अर्गानिजम जस्तो त्यसलाई ट्रिट गर्ने हैन
so yeah, यसमा देखिन्छ, can you see clindamycin, gentamicin, these are all IV. Can you give IV to the OPD patient for 8 hourly?
No sir.
Patient लाई IV 8 घण्टामा बोलाउँदै IV दिँदै गर्न सकिन्छ? It's not feasible. Okay, one is it's not feasible. अर्को कुरा त्यही भएर you can see ceftriaxone is intramuscular. हामीले किन intramuscular दिएको, IV पनि दिन मिल्थ्यो होला, but this is the patient the OPD basis मा. OPD basis मा intramuscular you can give. Okay, normally हामीले हाम्रो प्रेग्नेन्ट पेशेन्टहरुलाई पनि इम्युनाइज कहिले गर्छौं त, अराउन्ड मिड ट्राइमेस्टर तिर DT हरु दिन्छौं, intramuscular injection दिन्छौं नि. So intramuscular injection OPD basis मा दिन सजिलो छ. Okay, but IV को लागि चाहिँ we have to admit the patient. Okay, so that is the main reason. Okay, बुझ्यो? All the other regimen you can see सब tablet form मा छ कि छैन. So levofloxacin, doxycycline, metronidazole, all these are in the tablet form. Okay, ceftriaxone is only in the intramuscular form. Okay, त्यो भने OPD basis मा we can give, but IV therapy we have to monitor the patient. Okay, and admit the patient. Okay, so that's why inpatient regimen र outpatient फरक भएको कारण त्यो हो. And यसमा पनि हामीले ceftriaxone intramuscular दिन्छौं, so that can be substituted, दिन सकिन्छ, तर what the regimen, this is from the CDC को guideline अनुसारको हो यो. Okay, so there is also cephalosporin. So both पनि cephalosporin छ, यसमा पनि छ. Cefoxitin and cefotitan, though these are the first line, these are not commonly available. That's why clindamycin and gentamicin or ampicillin, sulbactam and doxycycline. Okay, so aim भनेको चाहिँ cover गर्ने organism चाहिँ तिनीहरु नै हो. Okay, so though the regimen is different, so multiple regimen किन दिएको भन्दा it varies. Okay, certain area मा चाहिँ certain खालको organism predominant होला, maybe mycoplasma होला, कतै Neisseria common, body common होला, कतै chlamydia होला, कतै anaerobes को बढी होला. So it depends. So ideally that's why we collect all the swabs culture हरु हेर्नी, त्यसको आधारमा we have to modify the regimen. It doesn't mean that hard and fast हाम्रो clindamycin र genta नै चलाउनु पर्छ भन्ने छैन, but these medication they cover usually wide variety of organisms. Okay, and within a day or two, एक दुई दिनमा त हामीले कलेक्ट गरेको स्वाब्स हरुको रिपोर्ट आउँछ, and we can modify the antibiotics as per the culture and sensitivity. Okay, so these are the starting regimen. It doesn't mean that you have to maintain the patient throughout 2 weeks with these regimen. यो हैन कि त्यही राख्नु पर्छ भन्ने छैन. Sometimes the gonorrhea, okay, they can develop resistance against the ofloxacin. In that case, you may have to switch with the doxycycline or ceftriaxone throughout or azithromycin. Okay, so we can modify it according to culture and sensitivity. Okay, ठीक छ. So this is just initial treatment. Later you may need to modify it. Aim भनेको okay, you have to start the treatment. Okay, and it should be for at least 2 weeks. Am I clear so far? बुझ्यो?
Yes sir, thank you.
ल. So if there is any query, then we can discuss. Okay, otherwise. Okay, thank you. So please send me all of your attendance. Okay, so CR, please send me attendance and. Okay, thank you.